Welcome to the deep dive. Today we're tuning into, well, the really intricate world of our ears, how we actually make sense of sound.
Hmm,
It's something, we often just take for granted, this ability to hear everything from, I don't know, a pin drop to a whole symphony.
absolutely.
But what happens when this really delicate system runs into a problem, a kind of glitch?
Right.
We're pulling apart medical surgical nursing guidelines today to really understand how our hearing works and, well, what can go wrong. Think of this as your backstage pass to your own auditory system.
Exactly. And we've gathered quite a bit of information here. Insights from medical textbooks, the basics of hearing loss, the tests they use to pinpoint issues,
Okay.
and then more detailed stuff on specific ear disorders,
Okay.
plus practical ways to communicate better with people who have hearing challenges.
So it's pretty comprehensive.
It is, yeah.
Yeah.
But the goal is really to boil it down,
Yeah.
get to the crucial bits that really matter for understanding.
Our mission for this deep dive, then, is to pull out the most vital knowledge from all this, make these sometimes complex medical ideas feel accessible, relevant to everyday life.
Mhm.
Like, have you ever wondered what those hearing test results actually mean?
Hmm,
Or maybe why some sounds just bother you more than others?
good questions.
Okay, let's get started. Let's unravel the basics first. The different ways hearing loss can actually show up.
Okay, so there's essentially four main categories, you could say. First, there's conductive hearing loss.
Reductive, okay.
This happens when something physically blocks sound from getting through the outer ear or the middle ear. Imagine like an obstruction, or maybe those tiny little bones in the middle ear aren't moving right.
Ah, like they're stuck or something.
Sort of, yeah. Then you've got sensorineural hearing loss. Now that's different. It involves damage deeper inside to the inner ear,
The inner ear, so the nerves.
right? Often it affects those really delicate hair cells. They're the ones that turn sound vibrations into electrical signals for the brain. Or it could be the auditory nerve itself that's damaged.
And what causes that kind of damage?
Well, it could be things like, interestingly, plaque buildup in arteries affecting blood flow, certain types of tumors, or even specific medications can cause it.
Autotoxic drugs. We'll probably touch on those later.
Exactly. Then number three is mixed hearing loss, which is, well, pretty much what it sounds
A
like.
mix of the first two.
Precisely.
Yeah.
A combination of both conductive and sensorineural problems happening at the same time.
Okay, and the last one.
The last one is central hearing loss. This is less about the ear structure itself and more about an issue further up the chain, like a disruption in the auditory pathways or the processing centers in the brain.
So the ear might be working okay, but the brain isn't processing the sound correctly.
Essentially, yes, that's the idea. And when we talk about how much hearing someone has lost, we grade it based on how loud a sound needs to be for them to even detect it.
Right, like mild, moderate.
Exactly. Mild, moderate, severe, and profound. Each level means a greater difficulty in just picking up sound.
Okay, so let's talk causes. What are some common reasons people develop hearing loss? I know age is a big one.
Absolutely. Presbycusis. That's the term for that gradual decline in hearing that often happens as we get older.
And that often comes with ringing in the ears, right? Tinnitus.
Very often, yes. That buzzing or whistling or ringing sound, tinnitus, is quite common with presbycusis, even when there's no actual sound there.
And I read something interesting about that type of loss. Does it affect certain sounds more?
Yes, typically with presbycusis, it's the higher frequencies that go first. This means people often struggle to hear consonants, like yes, if.
Ah, so that makes understanding speech difficult, even if they can hear that someone is talking.
Exactly. The sounds get muffled, less clear. Another really major cause, especially nowadays, is noise-induced hearing loss.
From loud sounds.
Right. Repeated exposure to loud noises, high-intensity sounds. It causes irreversible damage to those fragile hair cells in the inner ear.
It makes you think, doesn't it, about everyday sounds, like construction sites, concerts, even just headphones turned up too loud.
Definitely. Think about the sounds you encounter daily. What level, if you're exposed to it regularly for long periods, might actually be putting your hearing at risk? It's something to consider.
It really gives you pause, and it seems like with any of these causes, catching it early is key.
Oh, absolutely crucial. Early detection can make a huge difference in how well the condition is managed and what treatments might work best.
So how do doctors or audiologists actually figure out what's going on? What tests do they use?
Well, the main tools are hearing tests. Generally, that includes audiometry and also some simpler tests using tuning forks, like the Rin and Weber tests.
Okay, tuning forks. How do those work? Let's start with the RIN test.
Okay, the Rin test. So the clinician strikes a tuning fork to make it vibrate. First, they place the base of it against the bone right behind your ear. That's the mastoid bone.
Hmm.
You signal when you can't hear the sound anymore. Then, immediately, they lift it off the bone and hold the vibrating fork close to your ear canal without touching.
And you signal again when it stops.
Exactly. You signal when that sound fades.
So what's the point of comparing those two, bone versus air?
Well, it compares bone conduction hearing through the bone versus air conduction hearing through the ear canal. Normally, or if someone has sensorineural loss, you should hear the sound longer through the air.
That makes sense. That's how sound usually travels.
Right. We call that a positive RIN. But if you hear the sound longer or louder when it's on the mastoid bone,
Uh-huh.
that's called a negative RIN. And that usually points towards a conductive hearing loss.
Because the bone conduction is sort of bypassing whatever blockage is in the outer or middle ear.
Exactly. It suggests something stopping the sound from traveling normally through the air pathway.
Okay, clever. So bone conduction skips the outer and middle ear problems. What about the Weber test then? How does that fit in?
The Weber test adds another piece to the puzzle. For this one, the vibrating tuning fork is placed right on the midline of your skull, or your forehead.
Okay.
If your hearing is typical, you should hear the sound equally in both ears, like it's coming from the middle of your head.
Right. But what if it's not equal?
That's where it gets informative.
Yeah.
If someone has, say, conductive hearing loss in one ear, maybe earwax buildup,
Yeah.
the sound will often seem louder in that affected ear. We say it lateralizes to that ear.
Wait, louder in the ear with the problem. That seems counterintuitive.
It does, but think about it. The blockage stops outside ambient noise from getting in that ear easily.
Right.
So the sound conducted through the bone seems louder by comparison.
Huh. Okay.
Conversely, if someone has sensorineural loss in one ear, maybe from noise damage, the sound will usually seem louder in the better hearing ear. It lateralizes away from the damaged inner ear because that ear just isn't processing the sound effectively.
Got it. So these tuning fork tests give quick clues about the type of loss, conductive or sensorineural, and maybe which ear.
Exactly. They're useful screening tools. But for a really detailed picture, you need audiometry.
Right, that's the one done by an audiologist, usually in a sound booth.
Precisely. Audiometry is much more comprehensive. You wear headphones, and they play a series of sounds, carefully controlled in loudness, measured in decibels, dB in pitch or frequency.
Mm-hmm.
They play them into one ear at a time, and your job is just to signal whenever you hear a sound, even if it's very faint.
So they're mapping out your hearing thresholds?
Exactly. Across the whole range of important frequencies. This helps determine not just the degree of hearing loss, mild, moderate, etc., but also the specific pattern or shape of the loss across different pitches.
Okay, that makes sense. So we've covered types, severity, testing. What about risk factors? What makes someone more prone to hearing loss?
Well, there are several known risk factors. Family history is a big one, especially for sensorineural loss. If it runs in the family, your risk is higher. Also, certain congenital conditions, meaning things present at birth, like malformations of the ear structure.
Right.
And as we mentioned, some medications can be ototoxic. They can damage the inner ear. We should probably list a few later.
Good idea.
What else? A history of recurrent ear infections, especially middle ear infections. Having had bacterial meningitis is another risk factor.
Wow.
And of course, as we discussed, chronic exposure to loud noise. That's a major one. Finally, having a perforated eardrum, a hole in the eardrum, can also contribute.
Knowing all those risks, it really makes you think about prevention, doesn't it?
It really does. Things like using hearing protection in noisy places, being mindful of medication side effects. It puts some control back in your hands.
Definitely. Now, hearing loss isn't just about sound. What are some of the broader impacts it can have?
Oh, the impact can be quite significant. On a basic level, it can compromise your ability to hear warning signals like alarms or approaching traffic, affecting personal safety.
That's serious.
Absolutely. And in children, if it's not caught and addressed, hearing loss can lead to delays in speech and language development. That can have knock-on effects on learning and social development.
And how common is it, really? I saw some numbers.
Yeah, the statistics are quite striking. Something like 15% of adults report having some difficulty hearing.
15%. Wow.
And that number jumps significantly with age. By age 75, it's estimated that around 50%, half of people, experience noticeable hearing loss.
Half. Does that figure surprise you, or does it kind of align with what you see around you?
It sounds high, but when you think about friends, family, older relatives, perhaps it's not so surprising after all. It's very prevalent.
So if someone is diagnosed, what happens next? What are the non-surgical ways to manage hearing impairment?
Well, again, the first step is always early detection and figuring out the cause. That usually involves looking in the ear with an otoscope, checking the eardrum, and taking a really detailed history.
Asking about noise exposure, family history, medications.
Exactly. Then, depending on the type and degree of loss, hearing aids are often a primary tool. They're particularly helpful for conductive hearing loss, as they basically just amplify the sound to overcome that physical block.
Okay, hearing aids. Are there other devices too?
Yes, definitely. There's a whole range of what we call assistive listening devices, or ALDs. Things like amplified telephones, personal sound amplifiers for specific situations, systems that work with TVs, lots of options beyond standard hearing aids.
And what about communication itself? Strategies for interacting regardless of devices.
Communication strategies are hugely important. For some, American Sign Language, ASL, is their primary language, a complete visual language.
Right.
Others might use speech reading, which people often call lip reading. It can help, but it's tricky because many sounds look similar on the lips.
I can imagine.
Closed captioning on TV and videos is incredibly valuable. FM systems are often used in classrooms or lecture halls. They transmit sound directly from a microphone to the listener's hearing aid or receiver.
Cutting out background noise.
Exactly. There are also amplified headsets, TDD or TTY devices for text communication over phone lines, and even hearing assistance dogs trained to alert people to important sounds.
Wow. Quite a range.
And of course, having a support person, like a family member or a friend who can sign or help clarify, is often essential.
These are great resources, but what about just everyday conversation, face to face? What should we do to make communication easier with someone who has hearing loss?
Great question. There are several really practical things. First, try to reduce background noise as much as possible. Turn off the TV or radio, move to a quieter spot.
Oh.
Position yourself so you're facing the person directly. Good lighting is also key, so they can see your face, your lip movements, your expressions clearly.
Makes sense.
Get their attention before you start speaking. So light touch on the arm or saying their name. Don't just launch into it.
Right.
Speak clearly and at a natural pace. Don't shout. Shouting actually distorts the sound and can make it harder to understand, not easier. And don't exaggerate your lip movements either. Just speak normally, but clearly.
Good tip about not shouting. I think that's a common mistake.
It is. Also, be patient. Give them time to process. Rephrase if they don't understand, rather than just repeating the same words louder. And don't hesitate to use gestures or write things down if needed. A positive attitude helps too.
These are such helpful, considerate points, really practical. Okay, what about when non-surgical options aren't enough? Let's talk about surgical interventions.
Right. Surgery is usually considered for more severe hearing loss or when things like hearing aids just aren't providing enough benefit. A major one is the cochlear implant.
Okay, I've heard of those. Who are they for?
They're primarily for individuals with profound sensorineural deafness or severe hearing loss where hearing aids offer very little improvement.
How do they work, basically?
Well, it's quite amazing, actually. There's an external part with a microphone and a sound processor that picks up sound and turns it into digital signals. Then there's an internal component that's surgically implanted. It receives those signals and uses tiny electrodes to directly stimulate the auditory nerve.
So it bypasses the damaged hair cells entirely.
Exactly. The brain then has to learn to interpret these electrical signals as sound. It can be really transformative for people.
Incredible. Are there other types of implants?
Yes, there are other kinds of implantable devices too, depending on the specific type of hearing loss and the person's situation. Things like bone conduction devices, sometimes called BAHAs, and also semi-implantable hearing aids exist as well. Different technologies for different needs.
Okay, now let's shift gears a bit and talk about kids. Hearing impairment in children, are there special things to consider there?
Absolutely. Diagnosing hearing loss in infants and young children can be, well, challenging. Profound deafness is often picked up quite early, sometimes even before the baby's a year old, thanks to newborn screening programs.
Right, those are pretty standard now, aren't they?
They are in many places, yes. But if there's any suspicion later on, a full audiologic assessment is crucial. These tests are adapted for kids, of course.
How so?
Well, they're often done in a soundproof room. For older kids, it might involve tests where they repeat words or point to pictures. For infants, audiologists might use calibrated noisemakers, different sounds at different pitches and volumes, and observe the baby's reactions, like startling or turning their head.
And getting that diagnosis right is critical, I imagine.
Extremely.
Hmm.
Because sometimes, unfortunately, the behavioral signs of hearing loss in a young child can be mistaken for something else, like an intellectual disability or even autism spectrum disorder. So accurate diagnosis is paramount.
That's a really important point. So, what about caring for a child with hearing impairment in a healthcare setting, like a hospital?
Nursing care needs to be really thoughtful. It's often very helpful if a primary caregiver, like a parent, can be present as much as possible. They know the child's communication best.
Sure.
Nurses should always try to get down to the child's eye level when speaking to them. Face-to-face is key.
So they can see your face clearly.
Exactly. See your expressions, your lip movements. Also, make sure the child sees you before you touch them or start doing something. No surprises.
Good point.
Using demonstrations can help too. Show them on a doll or use simple gestures to explain what's going to happen. Having a nightlight can be reassuring, making sure their hearing aids, if they use them, are working properly and handled carefully.
Mm.
And if you happen to know even a few basic signs in sign language, that can go a long way in building trust and improving communication.
These are all really vital considerations. Okay, let's move on to some specific common ear disorders. One that seems almost universal is earwax buildup, impacted cerumen.
Yes, impacted cerumen.
Oh,
It's just when earwax builds up too much in the ear canal, it forms a physical plug, basically, that stops sound waves from traveling through the air to the eardrum properly.
and the symptoms are?
Usually things like ear pain, that's otalgia, maybe a feeling of fullness or pressure in the ear, and definitely a noticeable drop in hearing. Sometimes you can even see the blockage, like a mass of orange-brown wax.
How do they deal with it? Just scoop it out.
Well, not exactly scooping usually. The first step is often softening the wax. You can use over-the-counter ear drops for that. Then gentle irrigation with warm liquid, and it really needs to be warm. Body temperature can flush it out,
Why warm?
because using cold or cool liquid can actually make you really dizzy, trigger vertigo. So warm water is key if irrigating. Or a healthcare professional might use special tiny instruments to carefully remove the wax manually.
And the advice is always not to use Q-tips.
Absolutely. Definitely avoid cotton swabs or anything like that. It usually just pushes the wax deeper and makes the impaction worse. It can also scratch the canal or even damage the eardrum.
So the statement that impacted cerumen interferes with sound carried on airwaves is true.
Yes, completely true. It's a classic example of conductive hearing loss caused by obstruction.
Okay. What about other things getting stuck in there? Foreign objects.
Yes, that happens too, especially with kids. It can be anything from a bead to a piece of food or even an insect.
An insect. Oh, wow.
Yeah, that can be particularly distressing because you might feel it moving or hear a buzzing sound. Any foreign object risks scratching the ear canal, causing inflammation, maybe even poking a hole in the eardrum.
Symptoms would be similar? Discomfort, maybe hearing loss?
Yes, discomfort, reduced hearing, maybe that feeling of movement or buzzing if it's an insect. Diagnosis is usually just by looking inside with a light or an otoscope.
And getting it out.
Depends on what it is. For an insect, they might first put some mineral oil in the ear to immobilize or kill it, then flush it out or remove it. For solid objects, they use tiny forceps very carefully. Again, prevention education is key, especially for parents.
Right. Another common one, especially for swimmers, is otitis externa, swimmer's ear.
Yes, otitis externa. That's an inflammation, often an infection, of the skin lining the outer ear canal. Water getting trapped in the ear after swimming creates a moist environment where bacteria or fungi can thrive.
So it's an outer ear infection.
Exactly. Symptoms usually include redness, swelling of the canal, pain, especially when you pull on the outer ear, sometimes drainage, muffled hearing, maybe a fever or swollen lymph nodes nearby.
How's it treated?
Usually with antibiotic or antifungal ear drops. Sometimes steroid drops are added to reduce inflammation and itching. Warm compresses can help with pain, and keeping the ear dry is really important during treatment and for prevention.
Okay, now moving inward to the middle ear. Otitis media. That's the classic middle ear infection, right? Very common in kids.
Extremely common, yes. Otitis media is an inflammation or infection of that space behind the eardrum. And you're right, it's much more common in young children.
Why is that?
It's mainly because of the anatomy of their eustachian tubes, the tubes that connect the middle ear to the back of the throat. In kids, these tubes are shorter, narrower, and more horizontal than in adults.
So they get blocked more easily.
Exactly. Colds, allergies, even enlarged adenoids can cause the eustachian tube to swell shut or get blocked. Fluid then gets trapped in the middle ear, and it can easily get infected by bacteria or viruses traveling up from the throat.
And that causes?
Pressure, pain, sometimes fever, muffled hearing, tinnitus, just feeling generally unwell.
Yeah.
In really young kids who can't tell you their ear hurts, you might see them pulling at their ear, being unusually fussy or irritable, maybe having trouble sleeping or eating. Sometimes even vomiting or diarrhea can occur.
Are there specific germs usually involved?
Yes, common bacterial culprits are Streptococcus pneumonia and Haemophilus influenza, though vaccines have helped reduce the frequency of some of these. Viruses are also a common cause.
How is otitis media typically managed?
Well, it depends. Sometimes it's viral and clears up on its own. If it's bacterial, antibiotics are often prescribed. Pain relief is important too.
What about tubes in the ears?
Right. If a child has recurrent infections or fluid that just won't clear up, which affects hearing, they might need minor surgery. A myringotomy involves making a tiny slit in the eardrum to drain fluid. Often, they'll insert a small ventilation tube called a tympanostomy tube into that slit.
What does the tube do?
It basically acts like an artificial eustachian tube, keeping the middle ear aerated and preventing fluid buildup, while the child's own eustachian tubes mature. They usually fall out on their own after several months to a year.
Okay. And other surgical options?
Well, if the eardrum gets perforated and doesn't heal, a myringoplasty might be done to repair the hole. Nursing care focuses on managing pain, teaching parents how to give medications, advising on keeping ears dry if tubes are in place, recognizing signs of complications like rupture, and reinforcing prevention like avoiding smoke exposure and the benefits of breastfeeding for infants.
Got it. Now, another middle ear condition mentioned was otosclerosis. That sounds different from infection.
It is quite different. Otosclerosis involves an abnormal growth of bone, specifically around the stapes, which is the smallest bone in the middle ear.
The stapes, isn't that the one that pushes on the inner ear?
Exactly. It transmits vibrations to the inner ear. In otosclerosis, this bony overgrowth sort of fixes the stapes in place, so it can't vibrate properly.
Leading to hearing loss.
Right. Progressive conductive hearing loss, usually affecting both ears, or maybe not equally. It tends to run in families and often starts in young adulthood.
Any other symptoms?
Tinnitus is common, sometimes described as worse at night. Occasionally, the eardrum might look a bit pinkish-orange, called Schwarzschild sign. Diagnosis is usually through hearing tests, maybe a CT scan.
And treatment?
Hearing aids can help by amplifying the sound to overcome the fixed stapes, or there's a surgical option called a stapedectomy.
What does that involve?
They actually remove part or all of the fixed stapes bone and replace it with a tiny prosthetic device that can vibrate freely and transmit sound again.
Wow. What about recovery after that surgery?
There are some important instructions. Patients might feel some dizziness, headache, or nausea initially. They need to avoid things that increase pressure in the ear, like straining or forceful nose blowing. They should sneeze or cough with their mouth open.
Okay.
And keep the ear completely dry for several weeks, usually around 6 weeks. Also important to avoid anyone with a cold or respiratory infection, as getting sick could affect healing.
Lots to remember there. Okay, let's shift to the inner ear now. Vertigo, that feeling of spinning.
Yes, vertigo.
Yeah.
It's the distinct sensation that either you or your surroundings are moving or spinning when there's no actual movement or an exaggerated sense of motion. It's a balance problem, originating in the inner ear or the brain's balance centers.
Is motion sickness a type of vertigo?
You could call motion sickness a type of physiologic vertigo, yes. It's triggered by repetitive motion, car, boat, plane that confuses the signals between your eyes, inner ear, and body position sensors. Symptoms are usually nausea, vomiting, maybe paleness, and sweating.
And usually treated with over-the-counter meds.
Right, antihistamines like Dramamine or Bonine, or sometimes prescription anticholinergic patches like scopolamine can help prevent or reduce motion sickness.
Then there's BPPV, benign paroxysmal positional vertigo. That sounds specific.
It is. BPPV causes brief, usually intense episodes of vertigo that are triggered specifically by changes in head position.
Like rolling over in bed.
Exactly. Rolling over in bed, tilting the head back to look up, bending over, those kinds of movements.
What causes that?
It's thought to be caused by tiny calcium carbonate crystals called otoconia, or ear rocks, that have broken loose from where they normally sit in the inner ear and have floated into one of the semicircular canals.
The canal's involved in balance.
Right. These misplaced crystals then move around when you change head position, sending confusing signals to the brain that result in that spinning sensation.
How is BPPV treated?
Sometimes medications like meclizine are used short-term to suppress the dizziness. But the most effective treatment is often something called vestibular rehabilitation therapy, or VRT. Specifically, canal repositioning maneuvers, like the Epley maneuver.
Maneuvers.
Yes, specific sequences of head and body movements performed by a trained therapist, or sometimes taught to the patient to do at home, that are designed to use gravity to guide those loose crystals out of the semicircular canal and back to a place where they don't cause trouble. It can be remarkably effective.
Fascinating. Okay, another inner ear disorder involving vertigo is Meniere's disease. How is that different?
Meniere's disease is thought to be caused by an imbalance or excess of fluid, called endolymph, within the labyrinth of the inner ear. It's characterized by recurring episodes that typically involve a specific set of symptoms.
What are they?
The classic triad, or sometimes tetrad, is episodic vertigo, often severe and lasting minutes to hours. Tinnitus, often described as a low-pitched roar or hiss, fluctuating sensorineural hearing loss, which can become permanent over time, and a sensation of fullness or pressure in the affected ear.
So it's more than just vertigo.
Definitely. Attacks can also come with nausea, vomiting, nystagmus, those jerky eye movements, and sometimes people get a headache or feel off before an attack hits.
How is Meniere's managed? It sounds debilitating.
It can be. Management often starts with lifestyle changes, particularly a low-sodium diet to try and help regulate fluid balance in the body, including the inner ear. During an acute attack, bed rest and medications are key.
What kinds of medications?
Medications to control the vertigo and nausea, like antiemetics, promethazine, or vestibular suppressants like diazepam or meclizine. Diuretics might be prescribed long-term to try and reduce fluid retention overall.
And I remember reading something specific not to take. Aspirin.
Yes, that's highlighted. Individuals with Meniere's are typically advised to avoid aspirin and aspirin-containing products.
Why is that? Does it make it worse?
The exact reason wasn't detailed in our source material, but the guidelines specifically contrast it with the helpful medications. It implies aspirin might worsen symptoms, perhaps related to fluid balance or inner ear circulation, but that's speculation. The key takeaway is avoid aspirin if you have Meniere's.
Okay, good to know. Are there surgical options for Meniere's if medications aren't enough?
Yes, for severe intractable cases, various surgical procedures might be considered, ranging from procedures to shunt excess fluid to cutting the vestibular nerve or even destroying the inner ear structures on the affected side, though that causes complete hearing loss in that ear. Surgery is usually a last resort.
Right. Okay, one last disorder category. Ototoxicity. Damage from drugs.
Yes, ototoxicity. This refers specifically to damage caused by certain medications to the hearing structures, the cochlea, or the balance structures, the vestibular system, of the inner ear, or the auditory nerve itself, the eighth cranial nerve.
And symptoms would be?
For hearing, it could be tinnitus, or developing or worsening sensorineural hearing loss. For the balance system, it could manifest as lightheadedness, unsteadiness, or true vertigo, sometimes with nausea and vomiting.
Which drugs are the main culprits?
Several classes are well known. High doses of salicylates, like aspirin, loop diuretics, often used for heart failure or high blood pressure, certain antibiotics, particularly the aminoglycoside group, like gentamicin, some chemotherapy drugs, and even quinine, used for malaria.
So it's really important for doctors and patients to be aware of this potential side effect.
Absolutely, especially if someone already has hearing loss or kidney problems, which can affect how drugs are cleared, or if they're taking multiple potentially ototoxic drugs. Monitoring hearing and balance function is sometimes necessary.
Okay. Before we wrap up, let's revisit that scenario about communicating with a hearing-impaired child. You mentioned some incorrect and correct actions.
Right. So an incorrect action would be to speak directly into the child's impaired ear.
Why is that wrong?
Because doing that usually means the child can't see your face. They lose all the visual cues from your mouth movements and facial expressions, which are really important for understanding, especially with hearing loss.
Okay, makes sense. What else is incorrect?
Standing above the child's eye level when talking to them. You should always get down on their level face to face, and it helps them hear better and see your lips and face clearly.
And just speaking louder isn't the answer either.
Generally, no. As we said before, shouting distorts sound. It's not effective and can be counterproductive.
So the correct action is?
Speak slowly and clearly at a normal volume while facing the child directly. This combination allows them to perceive the sounds as best they can and make full use of any visual cues or lip-reading skills they might have.
That's a really clear set of do's and don'ts. Very helpful. Okay, so as we start to wind down this deep dive, we've covered a lot.
We really have.
We've journeyed through this really fascinating, complex world of sensory ear disorders. We've looked at the different types of hearing loss, the causes, how it's measured.
demystified some of those tests like RIN, Weber, audiometry.
Exactly. Underscored why catching things early is so vital. And then we walk through a whole range of common ear problems: wax, infections, otosclerosis, vertigo, Meniere's, ototoxicity.
And touched on management strategies, from hearing aids and communication tips to implants and pediatric care.
And hopefully this whole exploration has given you, our listener, a clearer, maybe more insightful understanding of these conditions, the incredible complexity of how we hear.
Yeah, and maybe this knowledge empowers you a bit to be more informed about your own hearing health, or perhaps to interact with people who have hearing challenges with a bit more empathy and awareness.
Absolutely. You know, considering just how intricate the mechanics of hearing are and all the different ways things can go wrong, it kind of makes you wonder, doesn't it? What other senses that we rely on every day might have similarly complex, maybe underappreciated vulnerabilities?
That's a really interesting thought to leave people with.
Definitely something to mull over. Thanks so much for joining us for this deep dive.